got fantastic people. It's got beautiful beaches. It's got wonderful communities. And as you've listened to people talk, it has so many intelligent, smart, innovative people doing so many things for the community and for the region, for the nation, and hopefully, for the world. So we've heard a lot of talks about research that's being done, and I split my time half doing clinical work at the hospital and half doing mostly clinical work at Matai, although I tend to be involved in a lot of the research projects. And one of the reasons why I really enjoy working at Matai is because I see it as a cheeky opportunity to siphon off all the awesomeness that we do here. And I use that word that's accurate. When Sam and Lee were first hiring people for Matai, it was, we want to hire awesome people. And I think if you see who's been on the stage, they've done a very good job. But my cheeky role is to siphon off the Matai expertise and directly roll it into better health care in this region. And since I have a foot in both worlds, I tend to kind of piss off people in both worlds, but I can also benefit people in both worlds. So on Sam's slides of the Matai projects, this has been called a research project. And that's like a misnomer to try to get funding from the research agencies. I'm going to describe a clinical project, a clinical pathway, a way we're treating patients and approaching disease in Tyrafferty that's based on siphoning off expertise from Matai. And I've chosen to do this in the realm of prostate cancer. And you'll see why the name later, but I have a picture of the local area. But like, this is not all of Tyrafferty, right? Like, the green in the upper right-hand corner is the region we're impacting, not just people who live in town. And the ultimate goal of this project is to take what we're doing, and I'll show you, I think successfully, Tyrafferty, and make it go nationwide. So prostate cancer is the most common cancer in men, just like breast cancer is in women. And of all the cancers in New Zealand, it sits only behind melanoma in being the most inequitable cancer. So Maori men and men living rurally are less likely to get screened. When they're diagnosed with much more aggressive disease, both in terms of histology and if it's grown out of the gland, so metastasized. They are less likely to receive invasive and aggressive therapies and are something like 7 times more likely to die of prostate cancer. So prostate cancer not only is a common disease, it's a disease where there is a big difference between different groups and how the outcomes arise. And the reason for this isn't completely known. So this road is supposed to be the journey of your prostate cancer diagnosis. And I put a bunch of roadblocks along the way because that's kind of the problem. So the first is lack of awareness and education. So a lot of people don't know about how you can screen for prostate cancer if you should. A lot of the information about the risks and benefits of screening are old and outdated, and they're based on this roadblock model and not the new model that I'm going to show you that we're doing here in Tyrafferty. I don't completely understand why there are so many inequities in access, but I think people have a general idea of why there are inequities in access. There are 2 tests for screening for prostate cancer. One is a rectal exam, and a lot of people don't like having someone stick their finger up the back passage. But even more than that, the GP can only feel the back of the prostate with their finger. But there's also a middle of the prostate and the front of the prostate. So the GP only feels the cancers in the back. So right off the bat, it's not a good test because you know it's going to miss cancers everywhere else. PSA is the name of a chemical in the blood that's secreted by the prostate, and it has a normal level. If that level's high, it suggests either the prostate's really big, it's inflamed, or there's a prostate cancer somewhere. And the problem with that test is that while it's very sensitive, meaning almost everyone who has prostate cancer will have a high PSA test, it's not specific, which means if that number is high, it doesn't mean you have prostate cancer. So if it's high, you might have it, but you might not. In every other part of the body, if we think you have cancer in an organ, we take a picture of it with imaging, and then when we do a biopsy, we aim at the part of that tissue that looks abnormal. But traditionally, that's not been the way we've approached prostate cancer. So the traditional way is you do what's called a systematic biopsy of the prostate. And I hesitate to use the word random because when the urologist does this biopsy, they try to aim for the left upper, the left mid, the left lower, the center mid. So they try to get a grid-like even distribution of the prostate. But lots of studies have shown that you really don't know where your needle is. And I've done these myself, and you really don't know where your needle is. So you're not totally sampling the prostate in a good way. So what happens is, even if there's a cancer, you miss it 25% of the time because you're not aiming for it. You're just sticking needles in. Okay? It turns out that even if there's not a cancer, these tests come back negative 25% of the time. So it's negative, but your PSA is still elevated. So you need more biopsies. It's negative again. PSA is still elevated. Need more biopsies. So it can result in a lot of extra biopsies of people who don't have a cancer. Since you don't know what you're sticking, your needle could go through, like in the middle here, the middle of a really small cancer. So the biopsy sample thinks you've got this, I hit the middle of it, got to treat it. It's a big bad cancer. That's this big. It's not going to kill you. Didn't need to be treated. But you don't know that because you don't have a picture of it. So then you end up treating a cancer that you don't need to treat, and the side effects could be impotence, incontinence, chronic pelvic pain. So you don't want to have bad after effects of treatment that you didn't need, right? Or you could hit the edge of a big cancer, underestimate it, and not treat it. Or you could hit the middle of a big cancer, and that's what you want, and you treat it, and everything's good. So this is not a very good test, right? So that's a roadblock. So if you decide to get a PSA test, and this is the way you're doing it, well, am I going to have biopsies I don't need? Am I going to have them repeated? Am I going to get treatment for a cancer that I don't need treated for? So there's a lot of uncertainties. Can you move the slide back one? Yeah. So because there's so many uncertainties, people decide not to do it. So then you don't get screened for it. So then no one's catching the disease early, and it's this cycle. So the process of diagnosing prostate cancer historically has not been good. Okay? So before MATI existed, and when I came to Gisborne, we started doing an MRI in everyone who had an elevated PSA who needed a biopsy. And we did that because a lot of studies over the last 20 years have shown that MR is pretty good at finding cancer in a prostate. It's not perfect, but it's pretty good. The size of what you think is a cancer on the MRI actually correlates with how big the cancer is when the surgeon takes out the gland and the pathologist cuts it up. So they match up, which means that if it looks like it's a centimeter on the scan, it's actually a centimeter in the prostate. That's actually pretty important if you want to know how big something is and where it's located. And it also turns out that if there's no finding on the MRI, then you're very unlikely to have cancer in the prostate. So that's pretty good. So what we did is we did MRIs in all these patients. And then when the urologist did the biopsy, they aimed their needle to where the MRI showed something abnormal. So it was still, so that's called a cognitive fusion biopsy. It's called cognitive because the urologist looked at the scan with me, and I said, okay, the tumor is about 2 centimeters this way and a little to the midline. So when they did the biopsy, they aimed about 2 centimeters this way and a little off the midline. And it wasn't perfect, but it was better than what we were doing before, right? We were actually imaging and then biopsying. And if the scan showed that you didn't have something that looked like a cancer, then maybe you could defer the biopsy and get followed up with more blood tests, get followed up with more imaging. It's not a definite answer, but you're not getting an invasive procedure as a result of an abnormal blood test. That could mean one of many things, cancer with just being one. So from 2016 to 2022, we scanned 240 men on the hospital scanner who had never had a scan before, never had a biopsy with an elevated PSA. And of those, 24% of them had a scan that suggested you don't have to have a biopsy. We can watch you, or your PSA is so low and the MRI is so good, you don't have to worry about it. Get a blood test again in 2-3 years. All right? We're estimating, and this is one thing I have to go back and get the data on, that about half of those biopsies came back positive, right? Which is better than 25%, right? So it's moving in the right direction. But those numbers still aren't great. Like there's still a risk of having a biopsy you don't need, and there's still a low chance of having, or intermediate chance of having cancer if you have a biopsy. What we want is, you're only getting a biopsy if you need it. If you get a biopsy, we're going to find something, because we want to reduce all those risks. So in August 2022, we got very lucky. We spent a lot of work trying to raise money through grants and the return to philanthropy, And we got $100,000 from the Prostate Cancer Foundation New Zealand to fund doing the scans on the MATI scanner as opposed to the hospital scanner. And it's not a knock on the hospital scanner. It wasn't bought to do prostate imaging. It's not spec'd for it. It does an okay job. The scanner at MATI is top of the line. It makes beautiful prostate images, really, really, really enviously good. We got almost $300,000 from this Ugreen Foundation to buy a machine that lets us do targeted biopsies. So this machine takes the MRI image, and I can draw a circle on the MR where I think there's a cancer. And the biopsies are done under ultrasound, but this machine fuses the images. So when I'm doing the biopsy under ultrasound, I'm not seeing the ultrasound image. I'm seeing the MR image with my circle for the target. So as I'm moving my needle, I can see if I'm going to hit the target or hit something else. So I'm actually aiming for the area that was abnormal. Now that might seem miraculous, but it's how we do it in every other part of the body. Prostate's just lagged behind for a long time. We also got some support from the company that makes that machine that gave us a bit of a discount on it. Okay, so I'm really missing a slide. Okay, so in the last year, we've been taking all men who have a PSA over 3.5 and who are under 70 years old, and we're using the funds from the Prostate Cancer Foundation to move those scans from the hospital to MATI. So it's cost neutral to the public health system. It's all done based on the grant work. We found that 41% of the 66 people who we scanned who have never had a biopsy with a newly elevated PSA, 41% of them had a scan that suggests they can avoid biopsy. And that number is 3 weeks old. It's probably gone up to 43. All right. We've done now 53 biopsies using the system. And of those 53 that we've done, one person really didn't tolerate it well. 2 people didn't enjoy it, but said they'd come back. And everyone else got off the table, kind of made a grimace, smiled, shook my hand, said, "Thank you, I'm glad I did it. It wasn't as bad as I thought." So that's good. Of the 47 people we've biopsied, 2/3 of them received a diagnosis of a prostate cancer that requires treatment. And about 13 of them received a diagnosis of prostate cancer that's low grade that can either be followed or treated or not treated based on preferences, size, age, other comorbidities. But we're avoiding biopsy in 40% of the people now who have abnormal PSA levels. And if you come to biopsy, you've got an 80% chance of having cancer diagnosed and a 2/3 chance of that being a cancer that needs to be treated. So the way I'm thinking about it, like we've taken that risk of having an unnecessary biopsy and taken it very, very, very low, right? So that's really, really quite good. How does the MR do? Well, when you read the MR, there's a scoring system, and without getting technical, you can say something is moderately suspicious, highly suspicious, I can't tell, or normal. And we biopsy the ones that look moderately suspicious and highly suspicious. So of the 41 that we thought were moderately suspicious, 44% of them were diagnosed as significant cancer. So the MR is doing its job at telling us what's cancer in the gland, and the biopsy has been allowing us to biopsy what we saw being abnormal. So why is this important? So according to the registry in 2021, only 30% of men in New Zealand who needed a biopsy got an MRI before getting a biopsy. Since 2016, 100% of men in Tyrafferty who need a biopsy have got an MRI before the biopsy. There are 2 other public systems in the country that do something similar, but they do it a little bit differently. So this is actually nation leading, right? We're actually, when these men come in, I can tell them, you're getting a service that's better than you'd be getting anywhere else in the country. And if you've been through our health system, that's a really nice thing to hear, right? I mean, that makes you feel pretty good. So this is what I summarized. So the risk of a man with PSA over 3.5 having unnecessary biopsy is low. So now we can go out in the community and we can educate people. We can go out in the community and we can tell them to get screened. We can do that with a good conscience because we know they're not going to have an unnecessary biopsy, that they're not going to have an unnecessary treatment that can result in unnecessary morbidity. And now maybe we can start tackling the low rates of screening and the disequity. Now, since we do this in Tyrafferty, it's open to everyone. You could run a trial like this in Auckland, but there's 1.2 million people. There's not enough scanners or biopsy devices to do this on everyone. But in Tyrafferty, we can do this on everyone. So it doesn't matter where you live, doesn't matter what your job is, doesn't matter if you can pay or have insurance, you come in through the public system through your GP, this is open and available to you. I put this website up because a lot of places that do new types of therapies, they keep their results to themselves. They wait, and maybe once every year and a half, they audit, then they publish. So every time we do a scan, every time we do a biopsy, I audit it, I update the results, I chuck it on a spreadsheet, and this website will give a summarized result of what the risks and the benefits are of having screened or getting a biopsy. And I do this so that GPs can use it as a reference so they can advise their patients properly, so that patients can look at it, and if they want to think about, well, what's the likelihood I'm going to have the biopsy? What's the likelihood it's going to be positive? It's there, and it's there in a rolling fashion. So if the next 30 cases don't turn out so well, it'll be reflected on the website in real time. And it's hard to know how other groups are doing because the data is not out there. So it's at this site. We'll move it to the Matai site at some point in the future. I know I'm over, but I'm going to keep going anyway. So still some challenges to go, right? I have to go back and look at the old data and see how many of those old biopsies were positive. Because if I want to get this adopted nationwide, right, I've got to prove that these numbers are better than the old numbers. And that's hard to do when you don't have the old numbers, and we've not really keeping those old numbers. So one big thing is to go back, look at all the medical records for biopsies in the region over the past 10 years. We have to go even further because we started in 2016 and get that information. We have to educate physicians and patients about the decreased risks with the new pathway. So this is one step. The website's one step. We need to go out in the community. I need to talk to GP groups, to go to iwi health providers, and that's something we'll plan on doing over the course of the next year. Really like to hire another urologist to do some of the biopsies, so if you know anyone, tell them the surf here is fantastic and the community is great. They should definitely come work here. The last one I thought was a hurdle, but the more I look around at other people doing studies, like there are other scanners that get images just as nice as the scanner that we get, and there are other radiologists who interpret them just as well as we interpret them. And there are other urologists who can do the biopsies just as well. So the thought of, oh, we have to train a whole country's worth of people, yeah, we do, but there's not just one place that has this expertise. Like there are a lot of people at places that aren't doing this that know how to do this. And that means it should be easier to get it going. So that's kind of my spiel here. What's really cool is that working at Matai, I get to run a clinical service using the advanced things. And this is the flagship project for that. But I have lots of other ideas and lots of other ways to leverage what Matai does to improve health throughout. So we're working with Gil to throw something together about mild traumatic brain injury. And we put some grant requests into the Heart Foundation to do things for atrial fibrillation and dementia. I'm working with Hari, and Fung is somewhere in the audience here I can't see. And they've developed really great ways to use MRI to look at lung that can be used for lung cancer screening. So prostate cancer is not the only thing that's amenable to leeching off the science and bringing it to clinical. So hopefully when we do this next year and 2 years, the talk won't be on prostate, it'll be on one of those other things. So thank you guys very much for coming. Thank you for listening. I hope you've enjoyed it, and just keep enjoying all the fantastic speakers that come, because this is just a really awesome event. Thank you.